So, greetings, friends and followers. This is Nurses Talking, and I am Dale Barzey. And as always, if you like what you see and hear, subscribe. Leave us a comment, let us know what you think. So, here on Nurses Talking, we speak to nurses anywhere in the world and at any stage in their nursing journey. And today, I'm very pleased to welcome Kali Dayton out of California. Kali is an adult gerontology acute care nurse practitioner. She's an expert in awake and walking ICU models. She's a transformative ICU consultant. She's an entrepreneur. She's got Dayton ICU Consulting. And she's a podcaster, walking home from the ICU. So, welcome, Kali.
Thank you so much for having me, Dale.
My absolute pleasure. My absolute pleasure. First of all, why are you a nurse?
Uh, Really, it started for me when I was about 14 years old. I was riding my bike and was doing pop wheelies, and the front tire went into a pothole, and I went over the handlebars, and the bike brake punctured my femoral artery. And I ended up in the hospital for a few days. I was fortunate to survive. There was a bystander that rushed over and applied pressure and called 911. It was just, the basics of scouting 101.
Yeah.
And he really saved my life. And while I was in the hospital under the care of these nurses, I just could feel spiritually that was going to be my future. So I had a lot of experiences leading up to this point that confirmed that I'm in the right place. But that was a very important milestone for me.
I can imagine. I can imagine. I think, I don't know if I know anyone else who can tell me that they've had a punctured femoral artery.
I bled from my femoral artery as well as my carotid artery. So just happy to be here.
Oh my gosh. So, having been so inspired though by nurses at age 14 is young teenage, and teenagers, we go through well, not we, but we go through all kinds of things in those years. Um, and you were laser focused on this. So what challenged you when you got there?
As far as getting to become a nurse.
And being in nursing school and nursing.
Yeah. I am the second of seven kids, and my father has his own business, and money was always really tight. So for me, figuring out how to financially go to college was a really big stressor. I was fortunate to get scholarships and not full rides, so I donated a
Yeah.
lot of plasma. Worked three jobs all throughout high school, odds and ends, and just that was a huge
Yeah.
struggle for me to figure out how to financially swing it. I did go to a 2-year program. This is back in
Mhm.
2008. Uh, got my associates. So I left when I was 19 and got my license right when I turned 20. So that was a really big, daunting experience. I didn't
Mhm.
feel prepared. I felt like I could barely take care of myself, let alone take care of other people that were really ill. So it was really growing up fast for me. I worked in a skilled nursing center initially and loved that. And then I became a missionary. I lived in Central America for 18 months in El Salvador and Belize and didn't do a lot of nursing care. I was helping with caring for the missionaries as far as their ingrown toenails and dengue fever, things like that. But it wasn't really like acute care or nursing traditional nursing care, but taught me a lot of life lessons that later played into the kind of care I gave as a nurse. And so when I returned back to the States, I'd had my license for 3 years but had never really worked in a hospital, but I wanted to go into the ICU. So I applied all over, and this is still during the recession, so there weren't a lot of
Yeah.
jobs open, but I had a lot of crazy experiences, spiritual experiences leading me to be interviewing into a medical surgical ICU in Salt Lake City, Utah, in the States. And I was very honest. I just said, I love Jesus, I speak Spanish, and I know very little about medicine or critical care, but you're going to have to teach me everything. And they were so desperate that, bless their hearts, they took me. And it was a huge learning curve. It was a really big challenge, but it changed my life forever.
And so, and so fast forward now, you are an expert in awake and walking ICU models. Number one, how did you get introduced to that model? And are you finding great resistance to it?
So that same ICU that I started in, that gave me a chance, it is an awake and walking ICU. So even during the interview, the nurse manager asked me almost immediately, would you be willing to walk intubated patients? And because I was so clueless and so new, I said, oh, I would love to do that, whatever that is, but you're going to have to teach me. And they did. But that was really the end of the discussion about it. When I started there, they treated walking intubated patients just as routine and optional as an antibiotic. So it was hang your antibiotic, titrate your vasopressor, take your patient on a walk, sit them in the chair, just normal. Everything was new to me. So I didn't question that. I worked there for a few years thinking that that was normal critical care medicine, that intubated patients were going to be awake, writing on a clipboard, walking around or doing their highest level of mobility, whatever they can do,
Yeah.
sleeping at night, unless they had exceptions like seizures or the inability to oxygenate with movement. There were times in which it was unavoidable, but those were the
Yeah.
exceptions. I barely knew how to titrate sedation. And so I did that for a few years. And then I became a travel nurse. At that point, I was 24 and I wanted to explore the world and have new experiences. So no one really told me what other ICUs were like. Uh, my mentor, Polly Bailey, did say, it's going to be different elsewhere. That's all she said. And I said, well, yeah, that's what I'm going for. I just want different, big experiences, bigger cities, right? Well, bigger cities. I first went to a little rural hospital in the most northeastern point of the United States, a town of 10,000.
Mhm.
And, but my first assignment in that new ICU, I got a patient that was intubated. And I wanted to continue my normal routine of talking to them, having them communicate back to me, doing a neuro exam, the full exam,
The
and
whole thing.
probably get them to the chair to wait for physical therapy. That was my routine. Us as nurses, we've got our routines.
Yeah.
And I went to do that, but they were sedated. They were unresponsive. They didn't communicate back to me. And I asked that orienting nurse, hey, can I get the sedation off and get them up? And Dale, she gave me the craziest look, like I was insane, and said, what? No, she's intubated. Which for me, having only really worked in an awake and walking ICU, did not make sense. So I said, I know she's intubated, but can I take sedation off? And why is she sedated? And her eyes just got bigger and bigger. And she said, because she's intubated, as if that should be enough. So it was the first time I'd ever been exposed to this, what I now know is common mentality, that all
Yes.
intubated patients are automatically sedated, that intubated equals comatose. And that was really confusing to me. But I also was new. I thought, I'm going to do what everyone else is doing. If this is what they do, it must be fine. What is normal must be benign. It must be okay. It shouldn't be, isn't that bad? And it seemed a little bit more convenient to me at the time. And so I just went with it. So for the next 2 years, I would kind of try to talk about what my first ICU did, but people just thought I was so insane that I just shut up about
Yeah.
it. And I just sedated everyone. I even laughed at it sometimes, because that was like the cool thing to do at the nurses station, is to laugh about knocking people out. I was wanting to fit in, which kind of makes me sick to say, but that's the honest truth, because that is
Yeah.
sometimes our nursing culture. It's like initiation to the ICU.
Hmm.
You're a real ICU nurse, you sedate your patients, you're kind of hardened. So I fell into that. I traveled to many other ICUs throughout the United States, and every other ICU was the same. But after a while, I had a lot of burnout. I didn't feel like I was doing much. I felt like I was working so hard, but my
Yeah.
patients were constantly having poor outcomes. I didn't really know who was in this body that I was caring for. I didn't have that human connection. I didn't have all these like fun success stories like I did in my first ICU. So I ended up going back to that first ICU, and I also went back to grad school. But when I went back to this ICU, I almost had another layer of shock to realize, oh my gosh, I wasn't crazy. I almost felt like I'd been gaslit, by all these other people to say, that wasn't a real ICU. Those patients weren't sick. You guys didn't really do that.
Yeah.
Yeah. Now I'm with these patients that are in multi-organ failure, septic shock, ARDS, high ventilator settings, and I'm walking them. And I'm looking around and no one's making a big deal out of it. But I'm like, hold on. All these 11 other ICUs I've worked in didn't know that this was possible. why do we do this? Why are we the only ones to do this? Because I was also doing
Yeah.
float pool. So I was going within the same hospital system, the same city, to numerous ICUs. So one day I'd be walking a super sick patient. The next day, they wouldn't let me take sedation off of someone that was much more stable.
Yeah.
So
Yeah.
it led me to finally look into the research, which is something that I wish I had done early on. I had gotten my bachelor's at that point. I'd taken research classes, but yet I went with what was normal, what was cultural, what I was told by mouth, rather than looking into what does the evidence say. So that's one of
Hmm.
my biggest regrets, that it took me that long to finally look into the research. And when I did, I was shocked to find so much evidence supporting what my first ICU did, that awake and walk in ICU. And every time I learned something new, I was like, oh, I wish I'd known this. And I'm certain that all these wonderful nurses, doctors, respiratory therapists that I worked with, and all these other ICUs didn't know this. Like, they would not do this to patients if they knew. So why don't they know? So why don't they know? Why didn't I know? And so I also had serendipitous interactions with survivors. Like, I was on a plane ride and I sat next to someone that had survived the ICU, and he had been in a medically induced coma. And he told me, as he sobbed to me, this man in his mid 40s, about what it was like to have his hands nailed to the floor, to the ground in the middle of a forest, and trees came crashing down on him. And the way he talked about it, I was like, he knows that wasn't real, right? And I said, you had ICU delirium. Like, that was so
Hmm.
obvious and not a big deal. In my mind, it was like, you were just confused, buddy. It's
Yeah.
fine.
Yeah.
But as I listened more empathetically, I realized this is real to him. He's
Yeah.
4.5 years out from his discharge from the ICU, yet he can still barely talk about it. I mean, he could only tell me a few things. He alluded to all these other things that he experienced, but he still could not verbalize them. But yet he was sobbing to a stranger on a plane ride. And that was really shocking for me. And I thought that has to be a fluke. I've done this for now, I think it was 6 years at that point. I'd worked in 11 ICUs. I thought I was so smart, so experienced, so knowledgeable. And I thought, if this is normal, I would have heard about it. I
Yeah.
would have known this, right? That's the way we get sometimes when we get so
Yes.
experienced. We feel confident what we know, but we don't know what we don't know.
Yeah.
So I went to survivor groups on Facebook just to check, just to make sure that he was unique. I thought I'd have to post about it, but I didn't. As soon as I was admitted into the group, I just had to scroll, and it was post on post and post about panic attacks, nightmares, flashbacks, craziest stories, the inability to go back to work because their brains weren't working, which led me to go circle back to the research and realize, oh my gosh, this is super common. A third of our ICU survivors have these cognitive, psychological, or physical disabilities long term. And a lot of it's from our care, from that sedation. And so all these things were kind of piecing together as I was working in Awake and Walk in ICU. I became a nurse practitioner during that time. And God told me very clearly to start a podcast. And I just kind of scoffed because I was like, one, I didn't know what a podcast was. Two, once I realized what it was, I was like, no one's going to listen to that. And that's what my colleagues told me too. They said, we've been trying to tell people about this for years. They won't listen to us. I had tried to talk about it with people, during my travels.
Yeah.
They didn't want to hear it from me, but I just couldn't shake this feeling. And so I started this podcast under very clear direction from God. And I was learning a lot. There's a lot that I didn't know. And so I kept it going during COVID, almost like investigative journalism.
Yeah.
I'm like, why do patients get extubated way sooner when they're awake and walking? And so I'd go and find these experts and we talk about it and dissect it. I interview survivors that had been sedated, also my survivors that had been awake and walking. And after a while, I started doing presentations remotely during COVID for teams, but there's just a lot that ICU teams have to understand, a lot of skills that they need um, to be successful. So that turned into now doing consulting, where I can provide a very systematic approach to help them implement these changes and master
Yeah.
them. I physically go on site with other experts and we do simulation training and hands on helping the clinicians really learn how to do this, not just making it an academic ethereal idea, but making it reality in their own ICUs.
Yeah. 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 And so after all this time, it's still an uphill battle.
Yes. So my first ICU, I didn't realize this until again years later. My ICU that I started in, that I call an awake and walking ICU. I only called it that because I didn't want my podcast to get shut down if I use the name of the hospital.
Yeah.
But they published a study in 2007, way back then, showing that
Yeah.
it was safe and feasible to walk intubated patients, even with a PF ratio of 89, which is to say that these lungs were really sick, yet it
Right.
was safe and feasible. And yet, still, 2025, I can go to conferences, interview nurses, physicians, physical therapists in the hallways randomly, and they will be like, "No, that's unsafe. It's unsafe." And yet, that's very old news. We've had many studies since that first one showing the same, that adverse event rates are less than 1%,
Yeah.
and that this drastically increases their ability to survive and go back to the lives they lived before. And yet, culturally, we still like just cling on to these old habits, myths, beliefs, misinformation.
Yeah.
It's wild.
Yeah. It's amazing how entrenched we can get in what we know or think we know.
Yep.
And God forbid anybody try to change us.
Well, and medicine is a field of evolution, right?
Right.
We're taught that from the very beginning of our educational journey in our careers, and
Yes.
yet an evidence-based medicine, and yet when new evidence comes out, we'd rather just do what we know. And we that's human nature, right? We are
Hmm.
all a product of our training and education and
Yeah.
experiences. So
Yeah.
it is really
Yeah.
challenging to suddenly say, let's do the opposite of what you've ever done or known. No, it is a big deal. These are sick patients, and it requires assessment before
Yeah.
initiating mobility, during,
Yeah.
after, right? But doing it early on ends up making it a lot safer. If you wait to mobilize someone once they've lost 40% of their muscle mass in 10 days, once they developed a brain injury and
Yeah.
delirium, and they're confused and impulsive and they have poor motor planning, all of that makes mobility a lot more dangerous. When
It's hot. Yeah.
they're so weak that they sit up and now their blood pressure drops, they become orthostatic, that's more dangerous. So I think it's much safer to mobilize them early on as long as they can oxygenate, they're
Hmm.
hemodynamically stable, even on vasopressors. Sometimes in some, especially cardiovascular units, they
Hmm.
increase the vasopressors or the inotropes to facilitate mobility. So I tell people, and I learned this from an OT, an occupational therapist, to see the ventilator like a walker. It's a tool for mobility. It's providing the support to safely mobilize. So if someone comes in the hospital, I think about like a lot of our COVID patients, they're hypoxic, they're working
Mm.
really hard to breathe, they're struggling even sitting there. But now we have a ventilator providing the oxygenation, the ventilation, the work of breathing. We didn't cut off their legs. Why can't they walk? So there's just a
Yeah.
lot of mentalities that can be changed once we look at it from a different perspective and with the science.
Yeah. Yeah. That's a really good way to look at it. That's a really good way to look at it. Yeah. So now you started your own consulting company. And so what would you say was your biggest hurdle pursuing entrepreneurship?
I never wanted to be an entrepreneur. I had watched my parents struggle with their own business.
Yeah.
Um, I married my husband who was an entrepreneur as well, and I thought, dang it, I did not want to live this life, but it's okay because I'll have this stable, steady job as a nurse practitioner. And then I gave it up to do this, which is no one else was doing this. I didn't have any mentors. I just feel like I'm bushwhacking my way through the unknown.
Yes.
So, I think just my own fears is a big hurdle. Um, this mentality is so persistent that I think sometimes it's hard for people to recognize that they need help.
Yeah.
They think that
Hmm.
they're practicing what's called the ABCDF bundle. It's a bundle of
Yeah.
care that should guide us to keep patients awake and mobile. So they think they're doing it, but they don't know what it looks like. They don't know what the objective is. So it's been years of saying just because you are charting certain things does not mean that you're actually providing this care. We're still harming patients. So it's been hard to broach that, especially since I was doing the podcast during COVID. That's a hard time to talk about these things.
Hmm.
Everyone's just doing their best. Now that it's settled down a bit and we're years out and people have seen so clearly the harm of what this does, they're starting to open up. But there's the staffing crisis, there's the financial crisis. So there's a lot of mentalities like we can't hire someone to help with this because we can't afford it, or we can't do this care because we don't have enough staff, right?
Yeah.
We can't get this equipment because we don't have enough money. So for me, it's been learning how to address those concerns with the evidence, because we know that this bundle, this ABCDF bundle, the more patients are awake and mobile, it decreases costs by 30%. So it's been, again, going back to the evidence saying, really? Like, can hospitals really not afford this? Oh, no, wait, they can't afford not to do this.
Mhm.
Is staffing a limitation? It can be. Some hospitals here in the States, we have 3 patients to 1 nurse. That's not feasible. But yet,
Mhm.
in my home ICU, it was 2 patients to 1 nurse, and yet we still never use sedation unless needed.
Mhm.
Then I had to think, okay, what is the cost? What's the burden to the staff on sedating patients,
Yeah.
keeping them on the ventilators for days to weeks longer? Can we afford that? So just figuring out how to address those concerns with the evidence. As I've been training teams, I've had more success stories. I've learned a lot. So it's just finding what are the hurdles and figuring out how to get over them every single time.
So, I want to ask, what what is your big vision for this?
Most days it's just to survive, but my big vision is to standardize awake and walking ICUs. That you go into any ICU and that it be like the one that I came from, where patients are sitting up in chairs, texting on their laptops, writing, watching TV, reading the newspaper. I mean,
Mhm.
newspapers are kind of fading out, but and that it not be a big deal.
Mhm.
That just like my home ICU, we'd be in rounds and we're like watching people walk around the unit while intubated, and it's just another day. That is my big vision. Now, for my business, I would like to be able to scale. So, as I've trained people and more people have from these teams have developed their expertise, my goal
Mhm.
is to borrow some of them to then go train other teams, because this requires a
Yes.
lot of intimate interactions, hands on, and I am one person. So I'd
Yeah.
like to be able to hire more nurses, more people. I'm just giving it time for this to grow more, also for them to develop their own expertise, because
Yeah.
a lot of people talk about this, but they haven't actually done it. And I don't want to continue that bad habit. I want to bring
Right.
in people that have actually done it to be the ones to be teaching it to the next team that is trying to make this
That,
transition.
yeah. 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 Awesome. 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 And your podcast will plant those seeds, to get that going.
Yep.
So awesome. What do you think you'd like to see change in nursing in general?
I would like to see nurses be really empowered to understand that they are not just there to follow orders,
Mhm.
that they are there to critically think, to offer suggestions, to bring ongoing evidence and research to the bedside, to update
Yes.
protocols and practices, that they lead this evolution, that they bring in the changes. That is a barrier at the bedside where nurses don't feel like they can challenge things. If a
Yeah.
physician orders sedation, they're going to be like, well, that's what they ordered, instead of
Yeah.
why? And approaching that physician and saying, I don't think this patient needs sedation. I don't think it's worth the risk because of X, Y, and Z. Let me try. And this whole process started with one nurse, Polly Bailey, back in the 1990s, where there wasn't research at the time, but she was
Hmm.
following her instinct and challenging the norm. At that time, we were giving Ativan drip, morphine drips, paralytics for weeks, causing a lot of damage. And she followed a survivor out and saw her in her home and saw how destroyed
Mm.
this young woman in her early 30s with 3 kids was. She went back to her medical director and said, we can't be doing this to patients. And he said, what is the research that shows? She scoured the research. There was none.
That's
Came
not.
back and said, let me try. And she gave it a try. And I want to bring in that kind of innovative, critical thinking, higher level of a nursing role to our profession as a standard, instead of being this
Yes.
one
Yes.
innovative pioneer that dared to do this because she was inspired, but rather every nurse feeling like that is my role. I'm
That is
not
my.
just robotic, but I am understanding why we are doing what we're doing, and I'm making sure that we are aligned with current research, not just what the cultural norm is at the bedside. And I can say that because I fell into that trap. Like, if anyone
Hmm.
is guilty, it's me, having been in an awake and walking ICU, having this experience, these skills, picked up and put into different culture, and I
Yeah.
just slid. I just went with it. So that I would like to see change where no one does what I did.
Yeah. Yeah, yeah, yeah. But I realized that you have that feeling of I wish I didn't. But I think it was essential for that to happen in order for you to be able to do this.
Oh, absolutely. If I hadn't been a travel nurse, I couldn't have done this.
You couldn't have.
It's, I mean, it's funny to think I send people to that ICU all the time to tour it. And initially, the people that work there, they're people that have worked there for 20, 30 years, right? And so when they have these visitors coming over from other countries or other states, they say, "Why are you here? You come from an even bigger hospital than ours. Like, how can we help you? What do you need?" And their eyes are big and they're just amazed walking through the hallways and seeing patients sitting up in the chair and giving the thumbs up while intubated. And my old colleagues are like, "And so,
It's no big deal.
what's the big deal?" And so they don't think it's significant. And
Yeah,
that's where I was at. So I would have stayed there. I couldn't have talked about what we do. I couldn't have taught how to change this if I hadn't experienced and even participated in these old practices and mentalities. I would not have been prepared to teach to the needs of those clinicians. I also couldn't say honestly, like, it's okay. Like, we've done harm. I've done harm. Let's learn from that and move on. Let's not burden ourselves with more moral injury or guilt. Let's just use that to look forward into the future because that's what I've personally had to do.
yeah, yeah, yeah. Awesome, awesome. I have one last question. We just talked a bit about burnout and all of this and how difficult and consuming it can be. So what do you do? First of all, what does self-care mean to you? And what do you do for self-care?
I mean, I have four little kids and one has special needs, and I'm maxed out right now. So I don't know that I am the master of self care, to be honest. But I've really come to appreciate it and have been humbled as I have reached my physical, mental, and cognitive limits frequently. Taking on this endeavor has been very
Yes.
consuming, as well as trying to keep everything at home going. So I have found frequently that when I don't fill my cup, I have nothing to offer anyone else. So I think that is absolutely a nursing mentality. A lot of times it's
Yeah.
these compassionate, giving, hardworking, competent people that go into the profession and they give, 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 and then there's nothing left to give.
Yeah.
So I don't know that I'm the master of it, but I've seen other people do that I am now aspiring to do is to step away, to
Hmm.
take
Hmm.
breaks and not feel guilty about it, to turn down a shift and say, I can't,
Yeah.
so that you can be fresher and more competent and prepared for your next shift. Um, to make sure that you are taking care of yourself mentally, physically, spiritually. Uh, Nursing is a very emotional job. And if you're not emotionally well, you can't fulfill that part of your job. Yeah,
Yeah.
you can give the meds, but nursing is more than that. So we have to heal ourselves before we can really be healers of others.
Yeah, yeah, and that is the reason. That is the reason I ask it of every single nurse because I know that we don't do it. I know how difficult it is sometimes to put ourselves in the equation and say, "Listen, I deserve to be taken. I have to be taken care of."
Mm-hmm.
It feels strange. It feels like we're putting ourselves in a round hole in a square peg. But I think more and more we're getting to realize that we really do need to pay attention and we really do need to take care of ourselves.
You know, we have our nursing brains at the beginning of our shifts, things that we have to do. We have to put that stuff onto our life, the list of our lives.
Yeah.
See it as like the mar of our lives. Like I have to
Yes.
I have to do it. Like if I don't do it, it's going to be pop up red and it's going to look bad.
Yeah.
I have to
Yeah.
provide this care to myself. Um, I talk about mobility as important and optional as an antibiotic. We know that those
Hmm.
antibiotics can save lives. We know that mobility can save lives, but
Yeah.
our self-care can save our own lives as well as the lives of others.
Yes. Yes, indeed. Yes, indeed. And and if we don't do it, I'm telling you, said put it on the mar of your own life, and it's absolutely imperative. It's imperative. I literally have to schedule it because otherwise, it doesn't happen.
Everyone else is going to be more important.
Yeah. Yeah, it does. Kali, I can't thank you enough for such an interesting conversation. Really, I have learned a lot. I would love to talk to you again. Thank you so much for doing this.
It's been my pleasure, Dale. Thank you so much.
Mine too, mine too.